Welcome back to Tumor Board with Hilario and Anish. I'm your co-host Anish.
And I'm Hilario.
So we're going to continue where we left off about our conversation about radiation oncology and what you need to know. So we mentioned a little bit about kind of different consults that we get. But Hilario, can you tell us, what are some common inpatient consults that sometimes the hospitalists or other providers may ask us to see?
Yeah, I guess like on top of my head is probably like, bone metastasis, right? Like the bone, someone has a bone metastasis that is causing pain. Pain is probably like the number one, right? Some of the other ones that people, we get is spinal cord compression. Actually, one of the few relative emergencies in radiation oncology, right? And then bleeding from hemoptysis or rectal bleeding or bladder, bleeding from the bladder as well.
So what would you say are emergent versus urgent versus not really that urgent?
So I guess like in terms of emergent, what's it called? RadOnc consult, right? I think the one that will probably come on is like spinal cord compression, right? And that's because the longer you wait for a spinal cord compression without the appropriate treatment, the worse the neurological symptoms can be, and the least likely it is to be resolved, right? So that is probably the most common RadOnc emergency that we see in the hospital.
That's really because that idea is, there's like acute spinal cord compression. Potentially, we can help restore function that they've lost. Right. I would say if it's someone who's, they've had this like weakness for 3 months or something, we really can't help restore function. In that case, it might not be emergent.
Yeah, and I guess like someone hemoptysis, depending on the degree of it, I definitely see why you can make a case for it being an emergency. But in those cases, I'm not particularly sure whether if someone's actively bleeding, then it would be an appropriate, what's it called, radiation oncology consult. It could be that they could go for, what's it called, try and do some kind of immediate intervention, like from a interventional radiology perspective, and then
or something,
right? And then we could come in if needed. SVC syndrome, depending on the grade of the SVC syndrome, can also be emergent as well. So those are the two that I can see as common. But by far, we don't get a whole lot of emergencies in radiation oncology, which is, for good or bad, is like the nice thing about our field, right? So what is our role in all of this? And like as a radiation oncologist, or even as a resident, because we see the bulk of consults in the hospital, right? How do you usually approach a consult? Let's say you went in Monday and then you saw a consult. What's your approach usually to a consult?
So the first thing is I always want to clarify why we're being consulted. And I think that just helps us, get frame in mind as to what we're trying to look out for, and if there's even something we can do for that. And then the second thing is really the full history of the patient. I think some patients have very long, extensive oncologic histories. So histories related to their cancer. They may have had multiple systemic therapies. They may have had radiation in the past. They may have had surgeries. And again, how does that relate to the problem that is happening right now? Another thing is their overall disease status. If they're on systemic therapy, is this the first line? Is this the fifth line? Is everything mostly controlled and this is kind of one area that's the problem? Or is everything, spreading rapidly? And again, tying that into what's happening now, but also the local disease. Is this, is there a disease at bay, but there's this like one tumor that's causing them pain or causing this bleeding, but everything else seems to be relatively okay? And also, the performance status, can they tolerate treatment? Can they be discharged? And do they have social support? Can they even be brought down from the inpatient ward to our department safely and be transferred from the table to our treatment table, or rather from the stretcher to our treatment table and back safely? Are they on some type of breathing instrument to help them breathe? They're intubated, things like that. What's going on in this overall picture of the patient, and why are we being consulted? And I think that also, we also a lot of times we talk to the other providers. So we'll talk with the medical oncologist or the surgeon or the pulmonologist or the IR doctor, depending on what we're consulted on, and to kind of see everyone's thoughts about what they would like to do. Like we mentioned before, someone has this bleeding mass causing hemoptysis and it's acutely bleeding. Maybe we're not the first people, so we'll see, hey, can Palm or IR do something about it first? And then maybe we can reevaluate later. But if they can't, then we want to get things going on our end. So and these are all the things we have to talk to all the providers and get a full kind of picture. And the other thing I did mention is look at the imaging. There has to be imaging. We really can't do anything without imaging because I need to know exactly what this tumor, what this disease looks like in order to even think about, what am I even trying to treat? And so we need as best imaging and as most recent imaging as possible.
Gotcha, gotcha. Yeah, I mean, that's a very thorough process there. I think that, one of the things that you mentioned is whether they've had prior RT. I think it
Mm,
matters, particularly, in terms of when they had the radiation, right? Because if
yeah.
someone had radiation a week ago to say,
Mm,
T5 to T7, right? And they've come to us and they're having that, and we've got a consult for that same issue, it is very, very unlikely that we're going to be able to give radiation to that person again safely, right? Um, Especially depending on the type, the amount of dose they got already. So those are considerations that we take into account. Sometimes the systemic therapy that you're on may not make it okay, or might make it not conducive for us to do radiation.
right.
And the ones that I can think of is like some people on VEGF inhibitors, right? VEGF inhibitors can sometimes cause issues with the blood vessels and sometimes can cause, abnormal bleeding with radiation, right? So the side effect toxicity from being on VEGF inhibitors for some patients, right? Like sometimes we want a washout period, right, before we can do that. So it is important to be for us to know that, or
Hmm.
we take a look at what kind of medications or systemic therapy that they are on, right? And then you already mentioned performance status in terms of whether the patient is able to lay flat, because usually we put patients in some form of flat position, whether it's supine or prone, right? So
Hmm.
it matters whether they can tolerate that. Occasionally, we can treat some people, at an incline, but the angle of incline is not too it's not as steep as some people may think. So even that, there's
Hmm.
not a whole lot of room for treatment in those. I think the big thing that sometimes happens also is the social aspects of a patient's care, right? So there might be um, there might be transportation issues for certain patients, especially patients where we get consult from, but like they're ready to be discharged, right? And they have to continue their radiation treatment coming from home, right? That can
Yeah.
influence our fractionation, our how many treatments we really want to give them. So if someone says, "Hey, I really don't have transportation," maybe social work can get involved in trying to secure some form of transportation. But if that fails, and that happens more regularly and often in the hospitals than we may think, uh, that may change whether we do maybe one fraction, for someone who needs some form of palliative treatment versus say five days of treatment or even 10 days of treatment, right? So also matters. And yeah, so is there any things, any aspect of a consult that you feel like, let's say, sometimes our colleagues miss and or did not consider
Mhm.
before consulting us, that this is not meant to be, like a negative kind of podcast episode, but it's meant to be more informative. That like these are some of the things that like sometimes can help actually facilitate the care of the patient, right? So instead
Mhm.
of them spending 3 days in the hospital, sometimes because of some of these things, they might end up being in the hospital for like a week or so. So, is there any things that you think that are crucial that sometimes our colleagues miss, and then we would like them to know?
I think, one of the big things, sometimes we get consulted on patients who we suspect to have cancer, but we don't actually have a tissue pathologic
Right,
diagnosis of it.
right, right.
And we typically, we're not going to treat just any mass because this is an irreversible treatment. It's not like a
Mm-hmm.
medication where potentially we get rid of the side effects by maybe another medication, but this is really irreversible treatment. We can't take it back. So we really need to know what cancer it is and what kind of cancer, because certain cancers, even, you know, radiation just may not be one of the initial forms of treatment, or it just may not be helpful in that setting. And sometimes we'll get these patients will be consulted that there seems to be some mass that's metastatic, but we don't actually know, what it is. And so then we really need to wait for that diagnosis. Otherwise, we're just not going to be able to treat anyone.
Mm-hmm.
Um, the other thing is imaging. Um, you know, we've I'm sure it's happened to many of us. We get consult and maybe there's a spread of cancer in the brain, or maybe there's something in the lung or somewhere else, but there's no imaging, or there's inadequate imaging. Maybe there's a CT in the head, but a CT is not the best imaging for the brain that MRI is. And there's not really much we can do with the CT because we don't know how many lesions there could be in the brain. We don't really know if that lesion even is a metastasis per se. It could be something else. There's other
Right.
pathologies that occur as
Right.
well.
And to that point about, imaging in the brain, for example, like, that can help us also decide, whether someone can get SRS, right?
Yeah.
Radio surgery versus whether someone needs whole brain because MRI is going to show how many lesions they have in their brain
Hmm.
and whether it is feasible to be able to do like SRS, for example, right? And to
Hmm.
your point about tissue diagnosis, right? If someone, let's say we see some disease in the lung, right, and that's suspicious that's where the primary disease might be, right? For example, right?
Right.
Depending on whether it's small cell or non-small cell, right? Someone we might not necessarily try and push SRS for someone who has small cell. It is definitely possible, but usually with something like small cell, we usually try and do whole brain, right? Because the idea is that radiosurgery is not necessarily the standard of treatment for those people. So I just
Right.
wanted
It
to
can
add that
change the
because
whole trajectory.
right,
Hmm.
right, right, right.
Yeah. And also, it
Yeah.
just allows more of like a fruitful discussion with the patient and more directed, and you can, be a little bit clear as to kind of potential treatment options with them. So I think those
Mhm.
two kind of are big things. And sometimes also this the oncologic history. It's, like we mentioned, it's really important to know any previous diagnosis of cancer, any previous treatments. But sometimes only when we start seeing the patient do we get kind of this information. And that could,
Mhm.
again, change the whole way we think about the patient and
Right.
whether or not maybe we need to, our other colleagues need to be consulted, et cetera. I would also say, when we want to treat a patient, again, because there's all these steps that we have to do, like we mentioned last time, where we do a simulation scan, we work with our dosimeters or physicists to create a treatment plan, then we treat the patient. Sometimes we just can't do it in the same day. And if we are able to treat same day or next day, it's usually a very kind of crude treatment where it's easier to plan. It's not as sophisticated. So we really reserve those kind of things for more urgent or palliative kind of plans. But I think understanding that it's not as sophisticated, this is really for kind of palliation or urgent treatments of some nature, and knowing that there could be a little time delay, I think is important for some of our colleagues to know.
Right. It takes time to simulate and plan, and depending on what our goals are,
Mm,
right? So if someone has localized disease and we think we can cure them, right? That's a different concept from someone with metastatic disease. And just like you said, if someone,
right.
the intent is palliative, then obviously we can turn around the radiation plan in a very short time. But if it is something that we're going for cure, right? Sometimes we have to make sure that we're coordinating with medical oncology if this is a cancer that needs some kind of radio sensitizer, right? So I guess what I'll add to the things that sometimes gets missed in the process of consulting is also making sure the other multidiscipline teams are aware of such a concept,
Mm,
right? So if it's brain mets with a lot of neurological symptoms, right? Neurosurgery is aware of the patient, right? If it is something that's localized, right? Let's say esophageal cancer, right? You want to make sure that GI medical oncology is also aware of it so that, the moment we're seeing the patient, we can all come together quick enough, right?
mm,
As opposed to that steps of like, finding out this is not happening and then adding on the next person. And those tend to drag things on and add extra days between when someone's disease is diagnosed versus when they actually started treatment. It could do that.
like you mentioned, especially when the kind of multidisciplinary team needs to be involved because we think there could be a more better way, like a more definitive way to treat someone. I think in some cases, just the way consults work, the radiation oncologist who's consulting may not be like an expert in that disease site. So in that kind of setting, sometimes just scheduling like a more urgent outpatient radiation oncology evaluation would be much more better. Otherwise, sometimes the patients get confused because they're meeting someone and this person is saying, well, this is what we're going to discuss, but we really need you to meet someone else. And that has to happen later anyways. So I think sometimes that could be helpful as well to kind of get that idea, if possible.
And yeah, that's a very good point. Uh, I think one thing that also that I guess it is slowly probably becoming a pet peeve of mine is that like
Mm,
if someone has cord compression, like unless there's any reason why they can't get steroids, right? They need to be on steroids like even before we're consulted because those neurological symptoms, the further they progress, the less likely that we can reverse it, even with radiation, that we can turn around the plan the same day or whatever, right? So sometimes it is important that, when someone comes in with a known oncologic history and there is some concern about spinal cord compression, maybe on CT, but they're going to get an MRI. I think sometimes it's prudent to start someone like that on steroids and just to kind of help preserve the function before even radiation oncology gets involved. Because I think that's something that maybe gets missed in all of
mhm.
this.
Yeah,
And
because
like I
steroids
said,
you can start immediately, but radiation, it'll take time even if we radiate. So you really want to start that as well.
right, right, right.
So, Hilario, we talked a lot about this, even on the last episode, what is radiation therapy? How does it work? What are the different types? When do we and how do we treat patients? The different kind of consults there are, what other providers should think about before consulting us, and also kind of how we approach or the things we consider when we look at patients. But can you just kind of summarize some of the things that we talked about?
Yeah, I think this was helpful, at least for me, even though I'm not on the other end of it as a hospitalist. I think it's helpful for me also to kind of process the way I approach consults. We talked about what radiation is. We're using high energy X-rays, right? We're targeting cancer cells or tumors. The reason why we're able to use them is because it can cause DNA damage to these cancer cells. And because cancer cells are not very good at repairing themselves and they are usually like multi-proliferating, right? So we're able to use that to our advantage to kind of sometimes kill them. We talked about the
Mhm.
different forms of delivery, external beam radiation and also internal radiation, also known as brachytherapy. And within those two, depending on what type of cancer an individual has and what type or the kind of side effects we're trying to minimize, we might use one or the other. We also talk about how long it takes to deliver radiation. Radiation can be a protracted process where it takes up to 7, 8 weeks even, right, to give the radiation.
Mhm.
And then sometimes we can try and shrink all of that into a few radiation treatments. And all of that is dependent on the stage of the cancer, right? And what kind of side effects that we can get away with. So if someone has a lot of issues or we are concerned about a lot of the organs in the area, right? We don't want to give a high amount of radiation in one setting. So that's something that we mentioned. We also mentioned this sometimes radiation takes even when we're delivering the radiation, it takes some time to take effect, right? So if someone was actively, say, bleeding, like copious amount of bleeding, it might not necessarily be that the radiation oncology come in first. It might be that they will need some form of intervention. So one of the things that we want as a team with hospitalists and radiation oncologists and medical oncologists to kind of come together to understand is that who is the appropriate person to actually go after a problem or a consult, right? So that's something that to consider. And also radiation and how long we do it for also is dependent on our goal, right? The goal being that whether this person we're going for cure versus whether this is palliative, we're trying to mitigate symptoms, right? So when we're usually trying to mitigate symptoms, our treatment is not as long as people that we're trying to take to cure or potentially cure. So that also factors into the timing of radiation. And then once we made all those decisions, it takes time to actually
Mhm.
simulate someone or plan the radiation that we're going to give. And part of that process involves not just us radiation oncologists, but it involves our radiation therapists, the people that are doing the simulation, and our dosimetries of physicists who have to come up with a plan that is both safe for the patient and also effective for doing the job that we wanted to do. So those are the considerations from our end before someone even starts radiation, right? And just talking about what we talked about in this episode, some of the things that needs to really be noted is that this person has have tissue diagnosis because radiation oncologists, cannot really treat something that they don't know what the diagnosis is. So it is important, and especially if someone, let's say, needs urgent treatment, right? It becomes even more imperative that we get tissue diagnosis. Knowing whether they've had radiation before and when they had it, usually someone had radiation more than a year from the day we're being consulted. It gives us leeway to be able to give radiation if we're doing that radiation to that same place again. So that's something that we consider as well. And I guess the last thing that we like is that I think cancer care really is a multidisciplinary so
Yep.
regardless of what cancer it is, like you want all the appropriate people involved, medical oncology, surgical oncology, and radiation oncology. And usually because almost invariably patients are going to benefit from seeing all of us and having a good plan before they go ahead with their treatment, especially if their cancer is curable. So those are some of the things that I think is important to know for oncologists and also for our fellow hospitalists and internal medicine folks in the hospital.
We hope this was a useful resource for all you, and we hope that you can learn something from it. And don't be afraid to reach out to your friendly neighborhood radiation oncologist.
Are
Play
you a
off what you
friendly
said.
radiation oncologist?
Yes.
Yeah, okay, good.
I think we all are.
Right. So again, if you like what we're talking about and you want to shoot us a message, our email is show notes. Please subscribe or like our episodes and and let us know what we're doing right and what we're not doing right in the comments. If you listen on a podcast app, you can follow us on Spotify, Apple Podcasts, and any app that you use for listening to podcasts. But thank you for tuning in this week, and we'll see you guys in the next one.